how to intubate patients, that kind of thing. And what we're proposing here is to use it to develop some more of the psychosocial skills of which really match that art and science piece within palliative care education. One of the pieces that I think is particularly important in this potential work is that they enhance competence and confidence of students. And so what I hear as an instructor within our interdisciplinary palliative care certificate program at Lakehead, they think it's all great to have all this sort of book learning opportunities. They can write papers, they can participate in discussion about what it could be like to be interacting with a person who is dying and their family, but they don't actually have the opportunity to get out there and to practice those skills. And I don't know what it's like where you're living, but up in Thunder Bay and area, it's very hard to get the clinical opportunities for students in palliative care education. So what students are looking for is that safe learning environment where they can take risks, they can really figure out how to make that link between theory and practice. And I think it's also important to recognize within the high fidelity simulation lab, it's not only safe for the learners to take those risks, because it's also safe for the so-called patient to be on the receiving end of those risks. Because we are knowing our population as Canadians, we're less willing to be those guinea pigs for our learners. So when we talk about, I'm sorry? You're not going to volunteer to die. Not going to volunteer to die. So when we talk about the psychological fidelity, what is that we're thinking about? That we're asking our learners to enter the lab not in a role playing, but as themselves, as a nursing student, a social work student, and to engage with the knowledge that they have and that they will be bringing to the bedside of someone who is dying and their family. And we work to find real life details that really make it believable. So an example that I was doing as part of a research study with Dr. Mary Lou Kelly with personal support workers, we'd gone out to the long-term care facility and we worked really hard to emulate the setting of the long-term care facility into the lab. And one of the things that we did is that there were these little codes of these little buttons that had somebody signifying as being a risk for falls or choking or that kind of thing. And we emulated that in the lab. So, of course, when the PSW is interacting with our mannequin, they look to the place where they expect to be able to get that information, and guess what? It's there. So they're able to continue on with what they do. Another thing that we do is that we have a family member come and visit and participate in that, because in palliative care we recognize very much that the unit of care is not just the individual who is dying, but rather the whole family in whom that they are living with. And so we did a pilot study with the hospice unit at St. Joseph's Care Group in Thunder Bay, and we invited the team to see if this was something that they might find worthwhile as a form of palliative care education. And all of a sudden there was a knock on the door, and the team moved to the door and completely expected that there would be some stranger who was saying that they are a family member to come and continue to be part of the scenario that they were learning in. So we find the literature speaks to this idea of the benefits of hands-on and bedside learning, and we strive to really replicate that. This is a picture taken from the lab at Lakehead University with some student learners, and the older gentleman sitting next to the mannequin is in that role of a family member. And so when we think of the need for interprofessional education, we think about learning with, from, and about each other. What a better way to do that when you're actually having an opportunity to be bedside with in a case study, learning from, with, and about. We're finding that students are able to problem solve, are able to develop relationships, and learn about some of those intricacies about where our roles have overlap and how we begin to really develop that theory into practice within our own discipline-specific learning. And of course, an important piece within the simulation lab is the opportunity to be able to debrief and reflect on what is going on and what happens not only to us as the healthcare providers and what we're learning, but what also happens to us as human beings, especially when we are in contact with individuals who are dying in their families, and what do we do with some of that stuff. And generally we find in healthcare we don't have enough time to really do that debriefing and figure out how our values, our judgments, and our personalities are impacted by the work that we do. And that's one of the things that we can provide as an opportunity after a simulation lab as well. So the purpose of my research for my dissertation is to explore how the pedagogical uses of simulation technologies may enhance and support interprofessional palliative care education for undergraduate students at Lakehead University. The intended audience is healthcare educators, specifically those with an interest in palliative care, interprofessional education, and simulation. The research question is, what are the processes, perceptions, and learning experiences of undergraduate learners of interprofessional palliative care education when they converge to learn together using high-fidelity simulation? So I'm also looking for things like development of communities of practice, thinking about death anxiety, and also the learning from, with, and about that occurs within interprofessional education. The methodology that I'm going to be Thank you. Thought as much. The methodology that I'm going to be using is grounded theory. I work from a constructivist perspective, so this is a very good fit for me as I'm striving to look about the social reality of learners in this kind of environment. So my participants, I have actually more than 12 very keen students right now, very interested in participating in this. They represent a variety of different healthcare backgrounds that we offer at Lakehead University. The prerequisite is that they will have taken the Introduction to Palliative Care course, which conveniently I have taught in the past. So I have an understanding of what kind of knowledge they will be bringing to the bedside, because I'm already looking for them to have some sort of grounding in that. They'll participate in 2 simulation labs. It'll be two groups of 6 participating in 2 different simulation labs. The simulation labs will focus on communication skills, and the second one will focus on advanced care planning. So both topics which fit very well with an interprofessional group of learners. I've also been part of some ongoing research which has helped to really sort of guide my dissertation focus with Dr. Mary Lou Kelly and her quality palliative care and long-term care projects. One of them we did was looking at improving communication around death and dying for personal support workers in long-term care using high-fidelity simulation. And another one Kim might be speaking to, peer-led debrief training using high-fidelity simulation, again for that frontline staff for long-term care. And I'm out of here, Sue. Thank you very much.
Wow. That's quite the experience. I think that's a really great opportunity for the students, and I look forward to hearing more about your research. Next up, we have Kimberly Ramsbottom. Kimberly completed her... Is that better? Josh, is that better? Okay. Kimberly completed her Honours Bachelor of Social Work at Lakehead University and is currently continuing her Master's of Social Work with specialization in gerontology. She is working under the supervision of Dr. Mary Lou Kelly. Her research interests include advanced care planning, good death in long-term care homes, and peer-led debriefing for long-term care staff. Kimberly is committed to continuing her career in gerontological research with a primary goal of integrating advanced care planning into Canada's everyday health services to ensure that good deaths happen for all Canadians. Is it already open? Yeah, it must be. Which one is it? This one, right? That one? Okay.
Thank you. I've been had the opportunity to participate in the simulation lab with Kathy, and it's amazing. And thank you to the ORC for supporting my research. All right. Oh. Interesting. All right. So I work under the supervision of Dr. Mary Lou Kelly and work on the quality palliative care for long-term care. The goals of the Quality Palliative Care Project is it's a 5-year SSHRC-funded project to improve the quality of life for people dying in long-term care homes. It is also to develop an interprofessional palliative care teams and to create a national toolkit that will be shared and to promote the role of the social worker in palliative care. As I said, the principal investigator is Mary Lou. Right. Our study background, this study was in response to a sub-study on the Quality Palliative Care Long-Term Care Project. Families indicated in the initial environmental scan there was a need to have open communication with families and staff. Knowing the advanced care planning wishes of a resident in long-term care can lessen feeling of guilt uncertainty and anxiety for the resident, for family members, and for staff. Families need to feel part of the team through advanced care planning and care planning. As I should give you a little bit of background. Originally, I was going to do a good death study, but with ethics, they had anxiety over the word death. So, so we decided to take a proactive approach and to study what we could do to create the good death before the death happened. So here, this is the transition into long-term care, the admission into long-term care, and how it goes, the resident's trajectory before death. We'd like to see the advanced care planning conversations happen post-admission, before end-of-life situations happen, before it's in crisis, before there's an emergency. And this can also, again, lessen the impact on family members and staff. So I had a good video, but we won't watch that. I don't think I have enough time for that. And so advanced care planning is an essential component to meeting the needs of residents in long-term care. Advanced care planning and care planning conversations can create a holistic care plan. There has been confusion in the language, so advanced care planning is the advanced care planning wishes before they enter long-term care. And care planning wishes, or care planning, is about the wishes that they're having during the care that they're receiving at that moment. Advanced care planning should be holistic, and there's some issues of who should have the conversations, when's the best time to have the conversations, and how to facilitate those conversations. So this is a qualitative study. We had 8 interviews with family members, 2 which were healthcare providers. It was semi-structured and open-ended questions. The interviews were transcribed verbatim, and the research assistants agreed upon the common themes. So advanced care processes specific to the needs of the residents and families are underdeveloped. Everybody agrees that advanced care planning is essential, but how do we initiate those conversations? And we don't have a formal process. That includes a psychosocial, a spiritual, a holistic, to meet all the holistic needs, care needs. So the lack of ACP makes care planning very difficult. At the time of crisis, family members are not in a good place to make those decisions, and it can be extremely stressful for everybody involved. The findings of the study can give guidance on areas that homes need to consider in developing their advanced care planning processes. So the themes that came out of the research that I've done to date, the family members would like to see that the staff are educated on how to have these conversations. It seems that everybody, again, agrees that the conversations are important to have, but who has them and at what time do they have them? Family members would like to also see that the long-term care home can educate them on their choices. So instead of taking a resident out of the long-term care home and bringing them to an emergency situation, it's best to provide care, quality end-of-life care in their home where they know the people that are caring for them. Timing. The family would like to see not having these conversations upon admission. Admission is a very high-stress time, and they'd like to see it 6 to 8 weeks post-admission. They'd also like to receive information on advanced care planning and care planning discussions upon admission. Knowing the resident. If you don't know the resident, how can you provide quality palliative care? If you don't know their holistic, their spiritual, their physical, their spiritual needs, you can't provide quality palliative care. Communication. This is the biggest part of the advanced care planning and care planning in order to have these discussions, you need to know the residents' wishes, values, and beliefs. If you don't know them, you can't, again, provide quality palliative care. It is essential for all staff to communicate with family members and residents for planning to provide the best resident-centered care. I've heard a lot about resident-centered care, and I again say you can't provide that without knowing the resident. Care needs have to be discussed before the end-of-life stage. Again, you can't have these conversations in an emergency situation. And care planning needs to be continuous. So you need to have continual conversations with family in order to provide quality palliative care. So the conclusions of this study, that healthcare providers in long-term care homes need to be aware of families, look to them for support and communication. All the family members want to have these conversations, but they don't know how to, and that they look towards the healthcare providers for supporting them. Families are receptive to the conversations, and there needs to be an increased communication with family members. I know that we all have this, there's not enough resources in the home to initiate those conversations, but we need to find a way to have them, and this is our hope. And that advanced care planning and care planning that is resident-centered can ensure a good death. So before the resident is receiving end-of-life care and emotions that are, highly stressful. And that's it for me. I encourage you to all complete advanced care plans.
Thank you, Kimberly. It's certainly something that reminds all of us to make sure that we have them in place for ourselves and for older people we may know as well. Any questions for Kathy or Kimberly?
I don't need a mic.
Okay.
I was working in community and worked with fourth-year university students as a preceptor for their community hours of anywhere from 200 to 360 hours. And not one single nursing student I worked with had any end-of-life palliative care addressed at all in their curriculum throughout the 3.5 years, because I usually got them right toward the end of their fourth year. And not a single one of them had ever been told about what a good death was and how we as healthcare professionals can help achieve that and teach and educate and support families through that. And so I think that is something that desperately needs to be looked at in university curriculums, is if we expect nurses to be able to teach families about a good death, nurses have to be educated to know what the whole end-of-life dying process is.
Thank you very much for that. I'd like to think, and the surveys that we're seeing from different universities are showing that we're getting a little bit better with our palliative care education across Canada. There's been some forward motion. I know I just finished teaching an introduction to palliative care courses last fall, and I had 90-something students. So, and that's across Canada. It's an online course, so we have learners from across Canada. So I think we're getting better with that, but unfortunately what you're saying here, I continue to hear from frontline nurses, generally out in the community when they're seeing students in their clinical placements. And we're talking about a younger generation of students who haven't perhaps experienced death on any level yet. And so you're then bringing them with you into a home, and perhaps they're now viewing somebody else's loved one dying, and then what do they do with that learning when they haven't been adequately prepared for that? So thank you for your comments.
Mike, would you like to make a
question to amplify what the last speaker mentioned there, and that is in terms of exposure to nurses, but so much of the front line relates to PSWs, and I'm wondering to what extent you are interfacing with PSWs. As bad as it is for nurses, there's a lot more PSWs exposed, I think, to that frontline situation. So what's happening there?
Well, thank you for that. So again, part of Mary Lou Kelly's Quality Long-Term Care, Palliative Care research study, because it's a participatory action research methodology, it was quite interesting. So a group of PSWs were at one of our local research days, and they saw a poster that my colleague Kristen Jones had up talking about using high-fidelity simulation. And the PSW said, we could use that. And so they mentioned it to Mary Lou, and next thing you know, we've got a small pilot project going with the PSWs. So we did 2 different groups of the PSWs through, focusing primarily on communication skills. From my perspective, it was fairly straightforward. We created a scenario that was quite realistic to their long-term care experiences. And it was, that 2 a.m. in the morning kind of thing when you come into the room and your resident rolls over and says, am I dying? What do you do then? And it was quite fascinating because our PSW learners at that point really ranged in experience of time on the job from 6 months to 20 years. And so they had a chance to, some of them, fumble their way through, some of them to confess, I didn't hear the question, and leave the room, to somebody really bringing out all sorts of practice, wisdom, and knowledge and personal experience and doing it really well. And so they had a chance to then pause the scenario, go back and work on something to see if it was how it felt and what they could adapt to and what they could learn from that. So we're hopefully doing more of that in the future. So
we have time for a couple more questions. Sorry, and I should get you guys to use the mic too. Ian.
For Kathy, I was wondering how important is it to be high fidelity, and can you get by with low fidelity?
Thanks, Ian. And I know why you're asking. We're applying for some money. Oh, thanks. Just to reiterate, the piece around that I think particularly for doing palliative care education is the psychological fidelity of it. And so what you create in the environment around the mannequin that matters. So the mannequins that we have at LU, in terms of being the high fidelity with all the bells and whistles, are upwards of $75,000. And when we're talking about really working on the lifelong process of learning communication skills, do you need all that? No. So as Ian was bringing up there, we can have lower end mannequins, but the big piece I think is important is that the voice comes out, and not just a computer pre-programmed voice. I wasn't clear about that when I was talking. So what we do is we do this kind of work in partnership. So Kristen Jones, who I was mentioning, is often behind the scenes, behind that two-way glass mirror, and is the mannequin voice. And we've developed a case study that, again, reflects the work of that our learners are involved in, and sort of has fleshed out all the nuances, so can actually react in that moment as close to a potential resident or patient might in that moment. And so as long as you can have that voice piece and you can work to create the psychological fidelity by having the realness of the case study and that in-the-moment reaction to that, I don't think you need the high fidelity with all the bells and whistles. But if you have a lot of money and you have access to be able to partner with a medical school or a nursing school, because you might be surprised at how many places, colleges, your hospital probably, your air ambulance, all those kind of things will have some sort of simulation out there. So if you can partner with them and to be able to do some learning that way, go for it.
We have time for a couple more questions.
I just wonder if there's anywhere that you can find information on teaching our nurses how to have that discussion for the advanced care planning. I would feel comfortable having that conversation with a family member with experience, but as a new registered person, staff member, I might not. And so where do you find that to educate the nurses?
We haven't found that yet. As part of this, though, I've now gone on to talk to the nurses, the nurse practitioners, and the PSWs. They all agree. They all support this information and this research, but we'd like to develop a toolkit that can help everybody that works in healthcare to have those conversations. So we're working on it.
Do you recommend having certain people in the home having that conversation to make it more consistent? And because I find that what happens is it is done on admission day, and a lot of the times it is a level where they are transferred to hospital with CPR, which isn't usually realistic, and it's because of who's had that conversation.
Mm-hmm. In the long-term care homes that we work with, they have the DNARs, and unfortunately that doesn't really encompass the holistic model. We'd like to see, and I mean this is the idea, that we do have a consistent message being told to families. So we are in the process of trying to develop something that can be like in our national toolkit. So we're working on it.
And if I can do a plug for the Canadian Hospice Palliative Care Association, they presently have a campaign called Speak Up. Speak Out, Speak Up. So if you go to CHPCA website, they have you can download a manual on what kind of questions to be asked. It's for individuals themselves, but I often find, and one of the strategies I use with my students is have them to fill out something and do some thinking about that themselves, which will then help them to facilitate their skills and their abilities to have those conversations with other people. So I'd recommend trying and doing your own first, and perhaps with your partner or your parents, and then try strategizing that way.
I think we have time for one last question. I think Sheila had her hand up first.
I wanted to offer a resource.
Oh, okay. And then we'll get one more in.
Sheila Cook, I'm a knowledge broker. I work out of London, Ontario, and the Southwest End of Life Care Network has a series of e-learning modules on plan of treatment for CPR. There's modules for nursing staff, PSWs, and physicians. Just go to their website and into the palliative care area. Those e-learning modules are available to anyone, and they've changed their name, and I can't, like Southwest End of Life Care Network is now called something else, but if you Google that, you'll find it.
So we can, there was two hands up over here.
I just wanted to mention the CHPCA Speak Up campaign. Some of the comments that they make are not applicable to Ontario law. So just be cautious when you're going through the work that they offer. That there's work being done now by advisory groups to pull it into alignment with Ontario. So just to have that in mind. Some of the information is different.
Yes, every program is different.
But it's a great resource. But just,
So we're going to switch topics now. I do invite you to continue these conversations with Kathy and Kimberly, who have posters downstairs as well. And they have put up their emails as well, so please do continue those conversations if you didn't get to ask your question. We'll move over to falls prevention now, and we have 3 early researchers working in this area and various topics there. And we're going to start with Luc Denomi, who is a second-year Master of Science at Wilfrid Laurier. He has a BSc in Kinesiology from Wilfrid Laurier, and he works under the direct supervision of Dr. Michael Sinelli, but he has collaborated on various projects with other researchers across southwestern Ontario. His research interests include neuromechanical control of balance during gait. He intends to pursue a PhD in neuroscience and continue research in balance control and falls management. You know which one is yours.
Thanks. Thanks, Sue. Great. All right, so today I just want to speak about the Nintendo Wii as a rehabilitation tool to try and improve balance in individuals with sensory-related balance impairments. And so I'm just going to begin with a brief understanding what balance is and the mechanical components associated with balance. So balance is just simply the ability to remain upright and prevent falling in humans. And mechanically, it's the ability to maintain our center of mass within our base of support. So here I have an image which looks at that little blue dot, which is around the navel area, and that shows the center of mass, which is the central point of the body, the total body mass. And so as long as that center of mass is held within the parameters of the base of support, which is the area of the body that's in contact with the supporting surface, which is that box, a person's said to be in a stable state. So once that center of mass leaves the base of support, they're said to be in an unstable state, and the risk of falling increases. And so as we stand, we naturally sway back and forth. So our central nervous system detects that and produces a series of compensatory reactions so that we increase the center of pressure under our feet, which controls the center of mass. So as we sway back and forth and our center of mass gets closer to the borders of our base of support, we increase that center of pressure to control that center of mass and bring it to a more stable state. And so that's going to be an important component to kind of remember when looking at how the Wii operates in a mechanical perspective. And so as humans, we require on regular feedback from our sensory systems in order to remain stable. So the three main systems that we rely on are visual, our vestibular system in our inner ear, and our somatosensory system, which primarily in balance control is the sensory receptors at the bottoms of your feet and in your lower limbs. And so as we sway back and forth, we're constantly getting feedback from our environment, feedback from these systems in order to remain upright and for that central nervous system to detect that. And so populations who have mobility impairments generally have decreased sensory sensitivity and therefore have less control of their center of mass. So their risk of their center of mass leaving their base of support is larger. And so there's many rehabilitation techniques for individuals who have balance impairments. However, most of them are individualized to that specific participant or that specific individual. So things like physical therapy training, independent physical activity, these are things that are generally used for individuals with balance problems. And they do provide evidence of increased balance. However, they can be costly, time-consuming, and difficult to generalize to the global population because they're patient-centered. And so balance impairments are also variable across conditions. So some people might require more frequent physical therapy or physical therapy for longer durations. And so in general, these physical therapy things as well are task-specific. So if you have a problem with balance during standing, then you train balance during standing, and that results to improved balance during standing, but it doesn't translate to necessarily balance during locomotion. So the idea that something that is inexpensive, time-efficient, effective, and structured is required for the general population of individuals who have balance impairments. And so that brings me to the research design of this program and the paradigm of the experiments that we've done using the Wii. So the main goals of our projects are to improve both static and dynamic stability in various populations who experience balance difficulties, more specifically that are sensory related in nature. And so the paradigm that we use is, or the objective is to determine if this static form of balance training using the Wii can translate to improved static and dynamic improvements in balance. And so this is just an image of the game that we use on the Wii, and it's called Table Tilt. So what it is there's a flat board and a ball on the board, and the goal is to get the ball in the hole. So it's kind of like that labyrinthine game. So you have to stand on the Wii Fit board, which this person's doing right here, and move your body forwards and backwards and side to side in order to control the plate and get the ball in the hole, but to make sure that the ball doesn't fall off the edge. So that's the gist of the game that we use. And so this act of shifting your weight back and forth, side to side and front and back, is pushing your center of mass towards the limits of your base of support. And essentially it's forcing your body to understand where those limits of your base of support are so that you can hopefully have greater control of your center of mass after you've trained on this for a period of time. And so the first experiment, we've done 3 experiments so far. 2 of them are completed and under review, and one of them is in progress right now. So the first experiment we did looked at older adults who were community dwelling and quite active and quite healthy. And so I should also mention that we wanted to make sure that if we saw results, which we anticipated we did, we analyzed them both using research-grade equipment and using clinical measures as well. So we want to see if we can improve balance, but if clinicians can detect these improvements as well as more sensitive research-grade equipment too. So the first experiment we did looked at older adults who were in the community, mean age of 68 years, and what we did is we used off-the-track, which is a motion capture system that detects a person walking in space. And this is a simple task that we did. So I had them walk along a straight path. Once they stepped on a trigger, one of 3 lights would illuminate, and the only instruction was to walk towards the light. And so this act of changing direction is a destabilizing event in the gait cycle because it's forcing them to change their base of support either to the left or to the right, and it's a challenge for them. And so what we found here were some improvements. The main improvements we found was improved balance during locomotion. So we used a specific calculation to assess how close their center of mass was to their base of support. And we also saw increased walking speed following the project, which are both good markers of improved stability during locomotion. The second experiment we did looked at a clinical population, so individuals who had peripheral unilateral vestibular loss. So that's a higher up inner ear problem that affects balance. And so here we decided to use clinical measures using 2 expert physiotherapists in that field of study and to determine if we could improve balance, and that could be detected through basic pen and paper type evaluations. And so what we did was we performed the dynamic gait index and timed up and go as our quantifiable measures. And we had 2 expert physiotherapists who were blinded to which group each participant was involved in. So we had a control group who were seated the entire time playing visual games, and then we had an intervention group who experienced both visual and somatosensory stimulation. And so this is just an image of the path for the dynamic gait index. So it's basically 8 different challenging events during a 20-foot walk. And so what we found here were improved balance during locomotion for both groups. So basic exposure to playing the game either in the control group and the balance group showed improved balance. However, the balance training group improved significantly more. So that just justifies the idea that balance training tool is more effective than just simply playing the game passively. And then the third experiment, which is currently in progress right now, is looking at individuals living in assisted living. And what we're doing is we're combining both research grade and clinical measures to assess balance. So what we're doing is we're assessing static balance using a Burtec force plate. So measuring how much they sway with their feet together, which is narrowing that base of support, which is a challenge to their balance control system. So we're measuring how much they sway with their eyes open, with their eyes closed. And we're also clinically measuring how fast they walk using the 25-foot walk. And so far we've collected 3 people, completed 3 people in this experiment. And some of the findings that we've seen, increased sway from side to side, which based on my general synopsis of balance would increase more instability. However, you can interpret it in one of 2 ways. You can interpret it that way, or you can interpret it in that the individual is now less conservative or less stiff when they're standing there, and they're allowing their center of mass to get closer to their base of support. So this could be a preliminary result of what could be happening, and then if they were to continue on, what we expect is that their center of mass actually gets more controlled. I also found increased walking speed during the 25-foot walk and increased balance confidence. So we also had them perform the activity-specific balance confidence scale, which their balance confidence improved after exposure to this game. So just quickly in summary, balance training using the Nintendo Wii Fit balance board is able to improve dynamic stability. And the Wii balance board is able to improve community dwelling older adults' dynamic stability, making it less conservative and stiff. And this is hopefully also the case in individuals in assisted living centers. And the idea is that training successfully forces the center of mass to the edges of the outside border of that base of support. And so then the balance board is also able to help improve clinical balance impairment as seen in those individuals who have acute peripheral unilateral vestibular loss. And improvements can be detected using clinical measures. So I'll stop there. And thanks for everybody that supports that.
Thank you, Luke. I'm thinking maybe I should go out and buy a Wii. Next up, we have Susan Muir. She's currently in her third year of her postdoctoral fellowship through the Division of Geriatric Medicine at the University of Western Ontario. She holds a PhD in epidemiology and biostatistics and a BSc in physical therapy from the University of Western Ontario. She's working under supervision of Dr. Manuel Montejo Odazo, and her research interests include the evaluation of risk factors, methods to identify at-risk individuals, and interventions to improve the understanding of the multifactorial nature of falls and functional decline in older adults. She has a particular interest in the rehabilitation challenges and needs of the cognitively impaired older adults, and intends to pursue a research career within a university setting, remaining in the area of her two professions as epidemiologist and physiotherapist.
So again, I would like to thank the ORC for supporting my research to be here. And my talk is looking at physical and cognitive exercises to prevent falls in older adults with dementia. So one of the emerging areas of falls research is the role of cognition in the control of postural stability. And as we already heard, postural stability is a very complex process and involves integration of information from multiple systems. Motor and sensory, which are ultimately processed through higher cognitive processes, in particular executive function, which we look at is how do we initiate, monitor, and plan voluntary movements, as well as attention, and in particular divided attention, and how we're able to multitask. Though we know that cognitive impairment is a risk factor for falls, how we define cognitive impairment does influence what that risk is. And we do know that impairment of executive function in isolation to impairment in global cognitive function or in the absence of a dementia diagnosis does lead to increased fall risk, whereas other measures of cognitive impairment do not. So when we're looking at these emerging areas of falls research, we're looking particularly at the areas of the prefrontal cortex where we're more involved for the executive function, as well as the hippocampus, which we primarily associate with memory, but it's also involved in visual mapping, visual spatial mapping, and that there is an interaction and pathways between the hippocampus and prefrontal cortex. So when we look at these areas and then we look at what happens in pathology, it leads us to Alzheimer's disease. And particularly in this group of individuals, they do suffer from postural instability. And it is actually not a late manifestation of a disease, but probably precedes a lot of the clinical features that would drive somebody to go seek assistance for impaired memory. That changes in gait and balance actually happen very early in the disease process. So why do we care about falls and cognitively impaired? Currently, about 500,000 Canadians have a diagnosis of dementia, and that's expected to increase by about 106,000 individuals each year with a new diagnosis of dementia. People who are cognitively impaired have an annual fall risk of about 60 to 80% per year, and that's at least twice that of cognitively normal older adults. So not only do people fall more often, but they're also more likely to sustain fall-related injuries such as hip fractures, and also at greater risk for institutionalization for falling. Even people who do not fall but are cognitively impaired, compared to those who cognitively impaired and fall, there's a 5-fold increased risk of institutionalization, and they're more likely to die as well. So when we look at fall prevention in the cognitive impaired, there's not much research. It's a bit of a fatalism of looking at it as a neurodegenerative disease and what can we do. But we do know that people who do have cognitive impairment can comply and participate in multifactorial exercise interventions, general programs to improve physical function, as well as complex exercise programs. And that this exercise training has been found to increase fitness, physical function, cognitive function, and lessen problematic behaviors. What the research has not been able to find is, do these exercise interventions actually lead to a reduced fall risk? And that the exercise programs that we know work very well in the cognitively normal do not translate very well to the cognitively impaired. So we need to look, are there other risk factors that are involved in this group in particular, but also need to look at novel interventions that actually accommodate to the disease process. So how do we actually evaluate cognition and postural stability? And this brings us to the idea of what we call the dual task paradigm. So while a person is performing a gait or a balance task, we ask them to do a secondary task, either a secondary motor or cognitive task simultaneously to the gait or balance task. And the thought is that attention, our ability to multitask, is a finite resource. And if we challenge that system by getting people to do multiple things at once and actually exceed their capacity, this attention capacity, then the performance on one or both tasks will decrease. Why does this matter? Well, we know that most activities of daily living involve multitasking, so it's simultaneous performance of two or more cognitive or motor tasks, and it probably are more representative real-life situations where people are likely to fall. And that from an assessment point of view, it probably gives us a better idea of what the person's true abilities or closer appreciation of abilities, rather than our standard clinical tests, which are very precise and very controlled environment and generally don't have much relationship to what the person does in their real life. So for the study that I'm doing was looking at, we know that postural instability increases during the performance of multiple tasks. And we definitely know that in the cognitively impaired, that is much more increased than just older adults, who definitely are different than younger adults. So we need to look at training balance in both single and dual task conditions for specificity and carryover, and that there's a novel fall risk prevention interventions are required, particularly for community dwelling older adults, where right now that's where the majority of people who have a diagnosis of dementia live. So the study objectives were to determine the effect of physical and cognitive training, or dual task exercises on gait, balance, strength, and cognitive function in community dwelling older adults. And then to determine the barriers to rehabilitation for people who have dementia, looking at both the person who's participating in the exercises as well as the caregivers. So the exercise intervention was a 12-week program for people who had mild to moderate Alzheimer's disease. Exercise program was done 3 times a week, and it was a home-based exercise program where the caregiver acted as the coach. The exercise program was prescribed by a physical therapist who graded both physical and the cognitive exercises, and then there was a home visit every 2 weeks to progress the exercise program. Exercise program was based on the Otago exercise program, which is probably the most well-studied fall prevention exercise program. We know it decreases falls. It also improves mortality. The exercise program includes lower extremity strengthening exercises, balance exercises, and a walking program. For our study, our novel contribution was pairing the balance exercises with cognitive tasks. So that was our dual task training, was through all the balance exercises. For our pre and post exercise assessment, we did cognitive testing on 5 different scales. We did physical assessments looking at gait and balance. Balance did multiple ways of testing, looking at 4 clinical tests, as well as posturography and forced platform measurements, and lower extremity strength. After the completion of the exercise program, we are looking to follow people for 1 year to see what their fall events are like. So in terms of recruitment, one of the barriers to rehabilitation is that we actually have had problems with recruitment. We've either reviewed or contacted directly over 250 people to be interested in participating in this study. And what we found for barriers of being in a research exercise study is, one, people are not interested in being at research. By the time it comes to people being accessible for me through specialized geriatric clinics or Alzheimer's day programs, they already have a lot of things going on. The other thing was caregiver burden. And again, by the time people become identified, caregiver burden is already a significant barrier, and people are not looking to take on anything more. If people were interested in being in research, they weren't interested in participating in an exercise program. So I'm going to present the results for 6 people who have completed the exercise program. I have 16 people who entered the home-based exercise program, but I have complete data on 6. So the sample was an older population, average age of 78 years, 83% men, mild Alzheimer's, relatively high active, and majority had no history of falls. What we found is that all participants were able to perform the exercises. They were very dedicated and motivated to the exercise program and did the exercises 3 times a week. And over the course of the 12 weeks, every participant was able to be progressed in their exercise program of both balance as well as the cognitive exercises. At the end of the 12-week intervention, we found that there was an improvement in executive function through testing on the Trail Making Test B. Gait strength and balance remained unchanged, though caregivers did report improved mobility and attention of their loved one, and that there was no added burden to themselves for being the coach in this exercise program. So in conclusion, in light of the recruitment barriers, particularly addressing the issue of caregiver burden, we've stopped the study as a home-based program, and now it's being delivered through an Alzheimer's Day program. And in terms of exercise, we still need to address issues of how to get people who are sedentary to start exercising, even though the geriatricians where I work always recommend exercise as part of what is good treatment. How do we get people to do that? We know that people with mild to moderate Alzheimer's disease are able to participate in this complex training program. We can statistically see gains in cognitive function, but we still need to look at methods to evaluate physical function performance. And then I'm still awaiting the 1-year follow-up information for functional trajectories and falls from this study. I'd like to thank the people who helped me with this study, and that's it.
Thanks, Susan. It'll be interesting to see your 1-year follow-up and see what impact you've had there. Finally, one more falls prevention talk with Lindsay, and then we'll move to some questions on falls prevention. So Lindsay Delama is currently in first year of her Master's of Science degree in Rehabilitation Science at Queen's University. She has a BAH in Psychology and Health Studies, also from Queen's. She's working as a research student with Dr. Rosemary Brander and Dr. John Puxty at the Center of Studies in Aging and Health at Providence Care. Her research interests lie in mental illness and community integration, with a secondary interest in older adult health and aging. She intends to pursue a master's in occupational therapy and later on a PhD in health sciences and blend therapy and research into a career.
Thanks, Sue. So what I'm going to be talking about today is the Canadian Falls Prevention Curriculum, but an enhanced model. And this model is actually being worked out of the Centre for Studies in Aging and Health at Providence Care, as well as with the Kingston, Frontenac, Lennox, and Addington Public Health Agency. So for some background information, 1 in 3 older adults fall at least once per year, and this is obviously detrimental because it can end up with hospitalization, psychological trauma, injury, and sometimes even death. So there is a need for training healthcare professionals working in seniors' fall prevention. So the original Canadian Falls Prevention Curriculum, the CFPC, was developed by Vicki Scott and her colleagues in 2007. And there are currently 2 formats. There is a workshop, which is a 2-day, all-day long in-person course. And there is an e-learning component, which is a 4-week online course through the University of Victoria. And the CFPC is a pilot-tested and evaluated program that has been shown to increase knowledge and skills in falls prevention, and it provides an evidence-based approach through that. So our study is building on the CFPC in that we have created an enhanced delivery model. So this means that we're blending both in-person and online components. So we hope to see increased access and participation through being able to participate online as well as in person. And this can also reduce costs such as travel costs, accommodation, and also we hope to see increased support. So there are opportunities for interagency collaboration. So agencies, they nominate people to participate in this program, and there's an opportunity for people within agencies and between agencies to collaborate, as well as monthly coaching opportunities to help them implement and sustain their falls prevention plan. And this model also aims to support the existing accountability structures, such as the Ontario Public Health Standards and the Ontario Long-Term Care Home Accreditation Standards. And so this study also helps to set the standard for evidence-based seniors fall prevention in the Kingston, Frontenac, Lennox, and Addington region, and also to encourage interagency collaboration. So in terms of participants, we're hoping to recruit 20 healthcare professionals across urban and rural areas. These participants are self-selected by agencies in which there are multidisciplinary teams working in long-term care, retirement facilities, or community support services. And these participants are either coming from direct healthcare backgrounds such as OTs, PTs, RNs, RPNs, or PSWs, or they're coming from administrative backgrounds, so directors or assistant directors of care. So in terms of our enhanced delivery model, as I said, it's a blending of in-person and online. So the in-person session just happened last Thursday, and it was an opportunity to network with others, to meet the people that they'll be speaking with online, and also to provide a base for their knowledge as well, so sharing what they already knew about falls prevention. And then after that, there is a 6 biweekly online sessions occurring from February until April. And these are online sessions in which they'll complete homework, they'll discuss problems and concerns at their facilities regarding falls prevention plans. And then they'll also have opportunities for monthly coaching through video conferences and online education systems. And these coaching sessions will help them to implement and sustain their falls prevention plan, and also help them to address any concerns they've had while trying to implement that plan. And then in September, there is an in-person wrap-up, and this in-person session will allow people to come together and provide feedback about what worked and what didn't work, and also to provide us with some evaluation information as well. So in terms of how we intend to collect our data, we're collecting data before, during, and after this course. So before, we collect information such as their demographics, so information such as how long they've been in healthcare and how long they've been in their current healthcare positions. We also created a knowledge, attitudes, and practice questionnaire regarding falls prevention, and we administered this to them in order to provide us with a baseline to compare after the course. And then with the traditional CFPC, we're using their pre-session test to also to evaluate knowledge. During the course, we're collecting data from the participant engagement data. So they'll be learning through the Education Learning Management System, the LMS, and this information will help us see how many hours they spent online, how many hours they spent in online discussions. And then after the course, in person, they'll complete the knowledge, attitudes, and practice questionnaire once again to help us compare, as well as the traditional post-test CFPC course content evaluation. So our methodology is mixed. We're collecting qualitative and quantitative data. So our qualitative information will come from the informal and formal feedback that we'll collect through online discussions as well as focus groups after course completion. And we'll also have quantitative data, so things like their demographics, the numerical values for their knowledge, attitudes, and practice pre- and post-test, and compare them, as well as the traditional evaluation forms from the traditional CFPC, so the pre and post, and then, as I just previously mentioned, the participant engagement data, so frequency of how often they were logged on. So the distinguishing features from this model compared to the traditional CFPC is that we're hoping that this will be more applicable. So when they congregate together online, they are encouraged to share real-life examples from their agency, and this will allow them to work together with others to help them overcome any concerns actually happening within their agency. And all their homework is also applicable to their agency. The accessibility components, so the combination of virtual learning and in-person provides a better time frame for delivery, so they're able to participate when they can. Increased support, so the opportunities for coaching, as well as interagency collaboration, as well as team interaction. So being able to meet each other in person allows them to get to know each other and then be able to put a face to the name that they're interacting with online. And then another distinguishing feature is the sustainability. So through coaching, they're able to identify their preparedness and ability to actually sustain their falls prevention plan. So there are 4 overall goals. So the first goal is to identify changes in knowledge, attitudes, and practice specific to this enhanced delivery model. And we'll be able to see that using the pre- and post-test questionnaires. Our second goal is to see increased engagement in online learning. So this is how we'll see the participant engagement data, and this will allow us to see how they've become more engaged over time. Our third goal is to provide a more accessible form of education for falls prevention plans with reduced costs. So we'll be able to collect this information through focus groups to see if this was more accessible for them. And then finally, our last goal is that the original CFPC in general increases their preparedness and practice for implementation of a falls prevention plan. And this is just an overview of the one questionnaire that we developed. So looking at their knowledge, attitudes, and practice. And that's all. Thank you.
So we've moved from training individuals on improving their gait through to looking at sort of more of or how can caregivers help and right through to training them. So any questions on falls prevention for these 3? Sheila has one.
I was just wondering who the coaches would be for to support the blended.
So the coaches would be the course facilitators. So there are 2 of them. One of them is a public health nurse who actually manages a older adult health team, and the other course facilitator is an occupational therapist.
In the back, do you Mike?
Are you going to look at the results of the implementation of the falls prevention program, the results from the education?
So far, we're just looking at the sustainability from that time point of coaching and the in-person session in September. But I don't know if John wants to add.
So this model builds on a template using several steps. It combines the idea of evidence-based practice using a standardized curriculum. Includes opportunities for quality improvement. So embedded within these sessions, they will, through this 6 formal curriculums, get a background also of quality improvement and change management. And so the idea of the coaching is then that they develop their own project, their own aim statement, their own indicators, and their own understanding of what PDSA is as it relates to falls prevention. So the idea is the organization will then hopefully, we hope several months down the road, get a report back to us on their quality improvement plan, their changes to their indicators, and hopefully their interest in ongoing. So each of the organizations, we recruited the organizations. So it's an organization who nominated itself, and then the organization identifies 2 to 3 individuals who are their champions or change agents. Does that answer the question?
Certainly. I stood behind them and spotted them every single time. So we trained for 45-minute increments. Whenever they needed a rest, there was a chair right behind me that they could sit in. And I was literally standing behind them with my hands over their shoulder every single training period. So yes, there were considerations.
Can I follow up? I'm sorry, I came in halfway through your presentation. I apologize for that. Okay. It was fascinating. But did you look at any issues of any change in lean body mass or arm girth, leg girth, or anything like that?
No, I didn't look at lean body mass or any of those physiological changes. We did look at differences in strength. So I didn't tell you all of the dependent measures that we used. We looked at lower limb strength to see if improvements may have been a result of increased strength of the legs, which there's nothing there. But we didn't look at any of those physiological things. No.
I think the whole area of cognitive assessment in terms of the potential fall risk is really important. Because relative to what you talked about, you started out with 250 people and ended up with 6.
Yeah.
What do you think there in terms of trying to encourage people to be part of a process? And are there other kinds of strategies that might work to increase your take?
Well, I definitely think for some of it is, as I went through the study, it was establishing the relationships within the community and finding ones that I hadn't planned on to do my recruitment initially. The center that I do, there are other parallel studies going on for people who have dementia. There are imaging and pharmaceutical studies where people get streamed to first and then kind of somewhere down the list. Even if it was just a regular fall prevention exercise program, there is a barrier of trying to get people involved in exercise. And of just having a better way of dealing with, again, how do we get people motivated to exercise? But I think as well, because whereas approaching people, we're after new visits to memory clinics where they would have a new diagnosis of dementia, that also probably was not the best time point because there were other issues going on that people needed to work through first before coming in and do you want an exercise program. So definitely been a learning process for me for dealing with this population, that there are so many other issues beyond just you're at a fall risk.
Following on, Susan, so had you thought about taking it back earlier in the diagnosis, so mild cognitive impairment? Because we certainly see a subgroup of those with some early visual spatial executive dysfunction before we diagnose dementia.
Yes. In an ideal situation, that would be the case. My supervisor, that's his area of work, is on people with mild cognitive impairment, and he currently actively recruiting people for a longitudinal cohort study. So was not looking to see what effects of exercise would do on measures of gait in this longitudinal study. So yes, that would be the ideal, is getting before people actually have transitioned.
Another thing in terms of the programs, fall prevention programs, neurophysiologists that I talked to suggest, as Lou has done, their medial lateral sway, gait speed, and gait variability are really significant in predicting high-risk predictors for falls. And I wonder if that's part of the curriculum or the sensitivity of the people that are developing this program that we're talking about.
Sorry, was that me? Or
Well, Luke could comment on that, but also the the curriculum program that you're using at Queen's, for example, does the content include those 3 items, which are known to be high-risk predictors of falls? So if you're doing a falls prevention program and you're educating the people about that, is that part of the content? I guess that's the basic question.
The curriculum, yeah, it does. As I say, it is a national accredited curriculum. It's been updated just in the last 6 months. So it certainly covers the broad range of content we want it to have. And what I think is attractive about it, it does already include this idea of course assignments. The traditional way to do it, as I say, it's either as a 2-day program, which you go away to, so you work as an individual, not with your team, or as an online experience, which is really training the coach, which is the mentor, to go back to the it's not the team. So what's different about this is we're offering a curriculum within a local champion team, and then offering them a 6-month continuous experience, 3 months of the curriculum, and 3 months of coaching afterwards.
I appreciate the process of that. I'm just wondering whether the content includes, for example, gait variability and how they would measure that. Does?
At the level of many people have been enacting the PSWs and RPMs. So it's not a training in standard gait assessment with respect to physiotherapy or even a nurse practitioner.
I'm going to open up the last few minutes for...
There's certainly talk things like the cut, the stand up and go, and some of the basic assessments display, and other risk perspectives.
I'm getting self-conscious about how much I might be playing up here now. I'm going to open it's all you guys are moving and I'm still. I'm going to open up the last few minutes to include any more questions you might have about the palliative part we heard at the beginning. So if there's any other falls prevention questions or palliative questions that you have for this group, we'll just open it up. In the back.
In terms of strategy, did the study include some measures to prevent falls, or like, say, fall monitoring, supervision of fall monitors or hip pads?
In terms of, for me?
Or like the high-low bed, because I'm a PSW in a nursing home, and to prevent the falls, we have these prevention techniques or whatnot. So I'm just wondering if you have these strategies.
Me specifically, known as strategies, I was more focusing on trying to focus on the mechanical aspects of balance and trying to change those or get people to work on the mechanical aspects of their balance in particular. So those internal models rather than the assistive devices. Not sure if that answers your question.
And Susan, yours is that people are at home still?
Yes, they were community dwelling and they were relatively high functioning physically. So, no.
And Lindsay, does the curriculum address that?
Well, so people would be able to bring examples specific to their agency. So if that is an issue or concern, then they would address that. But they do get the overall training with regard to overall falls prevention planning.
I have one for each topic. So in terms of the dual approach to falls prevention, I appreciate they had trouble recruiting with Alzheimer's, diagnosed Alzheimer's clients. Good luck doing it with MCI. I suggest that's going to be a real challenge too. Do you have any reason to suspect that you couldn't do this in a retirement home or in some kind of independent living facility where a diagnosis is your diagnosis required, or could your approach not be used in that population? And another question for the end of life, which is there's the intricacies of providing a good death. Part of providing a good death is making sure that the people have expressed meaning of their life as part of their death. I didn't hear either of you talk about that, so I wonder if you could comment on that aspect of providing a good death.
We'll start with the falls, and then we'll remind you what good death was.
Definitely, there's nothing to say that the approach to the exercises cannot be applied anywhere else. My part, particularly for my postdoc, is looking at mobility and fall prevention in the cognitively impaired. So I chose this one group specifically, and particularly because there is no research and a bit of a fatalism in that you can't change anything, or that particular group cannot participate in structured exercise programs. But you could definitely translate it into any fall prevention program in any population for older adults, for sure.
Kimberly, did you want to take that question about these? Kathy's got it first.
Thanks for the comment around meaning making and association with an appropriate death. I didn't go into any detail around sort of the curriculum and the pieces that would actually happen in the simulation lab, but both the topics that I'm choosing to explore around communication skills and advanced care planning lend themselves very closely to the exploration of appropriate or good deaths, and around the meaning-making piece. I think I know in the case studies that I'm developing, there's a strong link for that. So thank you.
I think that with the meaning making at end of life, without the communication, we can't really know what their end of life wishes are. So our whole focus is on having that communication.
Well, I think we'll keep it time so that you can have your break. I do encourage you two things. Take a look at the posters downstairs and to deposit your vote very soon, right? So if you haven't got those in, please do get them in right away over the break. And if you have any additional questions, please do come and see our researchers. And then get started. So we've got a mixed bag of research this afternoon, but there are all kinds of things that are related to long-term care in one way or another. So we're going to start with, how do you pronounce your last name? Sacco. We're going to start with Stacy Sacco. I see emails from these guys every day, but I don't actually get to pronounce their names out loud. Stacy is a second-year student at the Masters of Social Work program, specializing in gerontology at Lakehead University in Thunder Bay. And she holds undergraduate degrees in HBSW and Fine Arts and HBFA and Visual Arts. Her creative interactions and communication using art and music with people living with dementia in the community, long-term care, and palliative settings are some of her interests, and she plans to continue her research and education at a PhD level. So Stacey's going to start with some music-based research.
What if? What if I told you there was a very beautiful and very simple way to improve the quality of life for people living in long-term care, even if it's just for an hour once or twice a week? And what if I also told you, while doing this, you could increase intergenerational bonds and increase student learning about aging older people and the gifts that they have to share? What if? It is my favorite question because it supposes that there are consequences to actions and inactions, but it also leaves room for the possibilities for growth, learning, and change. Good afternoon. My name is Stacy Sacco, and my research project is Music Students' Experiences of Music Interactions with Residents Living with Dementia in 2 long-term care homes. Sorry. That's a lot to say. This project is part of the Quality Palliative Care Long-Term Care Project, in which Dr. Mary Lou Kelly is the principal investigator. It's a 5-year Community University Research Alliance project that's funded by a Social Sciences and Humanities Research Council grant, with additional funding from the Canadian Institute of Health Research for knowledge translation. That's just a slide. This is my funding. These are the people who made this possible. In the top center is Dr. Marg McKee. She is my supervisor. Dr. Dean Jobin Bevins, and in the middle over there is Lise Bourgeois. They were co-professors in the music class. Oh, I should tell you, it was called the Creative Community Engagements in Music. And it involved students from the second year to the fourth year. So the purpose and goals of our study was to understand the impact on the students who participated, to see if the opportunity to make music with long-term residents helped or had any kind of impact on their understanding of aging and dementia. There were 10 students who participated, 7 female, 3 male, all between the ages of 18 and 22. So these are students who just came right up from high school and went right to university. One student had worked in long-term care, and one student had done a high school co-op placement in a long-term care home. We used qualitative methodology to gather our data and interpret it. So 9 of the 10 students participated in a focus group, and 4 participated in individual in-depth interviews. All the interviews and focus group were transcribed verbatim, and those transcripts were analyzed meticulously line by line to support the emerging themes and the collective story that emerged finally at the end. The students reported, and this is how they reported to me, so this is how I'm reporting it to you. They experienced this on a timeline. So there was definitely a beginning, a middle, and an end, and how, because the course ran from September 2011 till April 2012. So they had, a good 8 months. This was done on non-consecutive Fridays, usually in the morning between 10 and 11. And so it did have a beginning, middle, and end. So in the beginning of the experience, there was a lot of confusion because only 2 students had experience in long-term care, and they were just put into the long-term care situation without any preparation of, people are not going to be necessarily fully cognitive, fully verbal, even fully mobile. So it was actually quite shocking to them. And Kathy, I'm just thinking about you. That would be such a fabulous thing to take students into simulation laboratory and have them learn in advance as a sort of a preparing for their journey into long-term care. But by the end, after all these interactions, they were able to really understand that people who have dementia, even advanced dementia, can still experience quality of life. And they were able to do that with music. And they have already they didn't realize that they already have a tool with them, with their music, as a way of communicating with people. So they also learned that through music, communication can be nonverbal and I like to call it cognocentric, because it doesn't rely on short-term memory or, that stuff. Do you know what I mean? It doesn't rely on short-term memory or being able to process information cognitively. It provides people living with dementia for successful interactions because the music that they did was music from the era of most of the residents. So this was one aspect of the communication that the students noticed. And I'm going to read you this quote because this is so beautiful. This is one of the younger students, never had gone into long-term care. They were expecting a retirement home and not a long-term care home. The one resident I had, she wouldn't speak at all. She would just offer her hand and she would smile at you. And she would just beam, though. She was so much happier. So those small moments of contact, the students, without any experience, recognized those as being hugely impactful and meaningful to the residents. So, for success for the students, what they need to be prepared mentally and musically. And musically, by that I mean because they're music students learning about music and not music therapy students, because there's really a big difference. I just want to kind of clarify that right now. Music therapy is a very special domain all on its own. And many of these students had never heard these songs before, and being a music student where your goal is to be perfect for every note. Because you train for performance, right? And that's what they're training for, performance. They need to be able to hear the music ahead of time. Also prepared mentally that people are not going to be able to communicate verbally. They also, another one, I have a poster upstairs, so it's got all the extra stuff on it, but they also need ongoing discussion and feedback. This was a pilot course. It was a huge course because they had the long-term care project, and they also had a project in a public school where they were, interacting with students and exploring conflict through music. So there was really no time to debrief or talk about their experiences, and that was another difficulty that they had. So, in conclusion, I'm just going to wrap this up because I don't want to time out. This is what they said about the end. And I think this is really the praise that we got. You're doing a great thing here. Meaning the residents, they don't get this very often. And it's to me, well, why not? If they were able to see the benefits without any real guidance or experience and were able to kind of pick up on it, why isn't this a thing that's happening all the time? And then another student said to me, this was a part of their learning experience. I think the positive learning aspect, was just seeing different ways that I could incorporate music into different facets of life. You don't need to focus on performance or education. You could use music to improve people's lives. So I'm going to just leave you with this. A little question here. My final thoughts and perhaps a direction for future research. Following along the whole timeline thing of a beginning, middle, and end, here's the question. What if this class, this project, with what we've learned about what students need for success, what if this student joint venture into long-term care, into the lives of people living with dementia, is just the beginning? What if? Thank you.
So we'll have about 5 minutes of questions for Stacey. And if I can get you to use the microphones, that would be great, because we are recording the questions and the answers as well, and I didn't realize that last session, so my apologies.
Nature abhors a vacuum. I'm wondering, actually, if you considered collaboration with a music therapist, not to bring them into a music therapy career necessarily, but if music therapy is all about reaching in and communicating in a different way with people, which even if you're going to be a performance artist, isn't that really what you're trying to do? So have you explored links like that, and what might that look like as a curriculum?
Oh, I'd like to do that in a future program. Have more interdisciplinary and interdisciplinary collaborations, so that in a larger course like this, maybe you would have not just music students or not just art students or theater students or drama students, but also nursing students, kinesiology students, psychology students, in a large kind of cross-discipline where everybody can learn from each other. And hopefully a music therapist would join us. Thunder Bay is not that large a city.
Do you have a music therapy program at your school?
We do not. They'd like to, I think. That's like a thought for the future.
So collaboration would be the best way to do it.
Yeah.
Any more questions for Stacey at this point?
Hi. I just had a question with respect to, looking at your sample population and everything. Putting students in a long-term care home, comes with a set of challenges. First of all, that population, the residents, are one of the most highly protected, vulnerable populations. And it seems like, did these students go under any training or anything like that? I'm really curious as to how this passed an ethics review board. Were there mitigating, ways to mitigate interaction to make sure both parties were
protected, or?
There was always staff involved. Like there was staff as well as family caregivers at the music interaction sessions. So there was always like a professional involved. And you know what? They didn't get thrown into a situation where someone was going to become really agitated with the music. And I have to give it to the staff at the 2 long-term care homes that we were at. They know the people inside and outside and upside down. And you know, if they felt like someone was going to be agitated that day, they did not have the students come into that situation.
We'll open up after if we have more time to more questions. But thank you, Stacey. We'll next move on to Julie Dergal. She is currently a CIHR postdoctoral fellow in the Department of Epidemiology and Biostatistics at the University of McMaster. She holds a PhD in social work from the University of Toronto, which focuses on family members' use of private companions in nursing homes. Her research interests include palliative care in nursing homes, caregiving for older people with dementia, elder abuse, homelessness among older adults, and aging with a disability. Under the supervision of one of our ORC professors, Professor Renia, her postdoctoral work is focused on development and validation of a new screening tool to detect autism in later life. She intends to pursue a career in academia and research and establish a program of research in aging and autism.
Thanks, Sue, for the introduction. So I'd just like to share with you a little bit about the work that I'm doing. And right now what I'm doing is I'm looking at developing and validating a tool to detect autism in later life. I'd just like to acknowledge the funding sources for this work, so my CIHR postdoctoral fellowship, and of course the Early Researcher Award. So autism is a common neurodevelopmental disorder which is often associated with childhood. The proposed DSM-5 criteria suggests that autism is a dyad structure which consists of a social communication and repetitive behavior components. Canadian data currently suggests that 1 in 94 children are diagnosed with an autism disorder. Autism disproportionately affects males to females in about between 4 and 7 to 1. Autism is associated with substantial social, communication, and behavioral challenges. And there's a lack of research examining autism across the lifespan, and in particular in later life. So most of the research that we have looks at the assessment and treatment of autism in childhood and doesn't move beyond into older age groups. So our knowledge base sort of cuts off in the 40s. So as I said, there's a lack of research, particularly among those 50 and over. Today we have the first group ever to age with an autism diagnosis. So autism was first diagnosed in the 1940s. So this group is now in their 70s today. So we don't have any information at all about this older age group. Research suggests that autism is currently being assessed in adulthood for 2 reasons. One is adults have gone undiagnosed in childhood. So they would currently experience difficulties in their relationships, or I should say a pattern of difficulties in relationships or maintaining employment, and then would be referred for assessment. The other reason that they're being identified in later life as opposed to childhood is because they've been misdiagnosed. So they may have been diagnosed with schizophrenia or bipolar disorder or some other neuropsychiatric condition, but not the right condition. So we currently don't have any validated measure to look at detecting autism in later life. So studies that do include adults or older adults, which there are very few, they're using measures that have been used to assess autism in childhood or in younger populations. So we need an age-appropriate measure that is validated in use in older adults. And I see developing this screening tool as the first step in establishing a larger program of research that examines aging and autism. So overall, I think it's important because we don't have an idea about whether the clinical features of autism change over time. So are they the same in older age? We don't really know. We don't know how it changes across the lifespan, if at all. So I'd like to highlight some. It would help if I did I not? Sorry. How did I go? How do I go back? Sorry. That's forward. I don't know how to go next. Previous?
And one more.
What? Okay. Sorry, I'm not very technologically savvy at all.
It.
And then, sorry, again, previous. Oh, one more. That's where we started from? Okay, thank you. Okay, sorry about that. So here, I'd just like to talk about some of the work that we're currently doing. So we're in the process of doing a systematic review to look at all of the literature, to look at the existing measures for screening or diagnostic measures for autism, so being used in younger populations. So the idea is that we will pull those screening measures and pull the items from those measures and include them as an initial draft for our screening tool. And so that's in process. The other thing that we're doing is we're planning a research meeting to bring together researchers from autism, aging, and developmental disability from Canada, the United States, and the UK, so that we can sort of pool our expertise in this area, because really this is a very new area of research and there's not much expertise to draw on. We're currently in the process of submitting a grant, and I'd just like to talk about that study for a little bit for the next few minutes. So the objective of our study, we see it as a sort of a two-phase study. One is to develop the content of a new screening tool, and the second is to really assess the measurement properties of that tool. So I'd just like to talk about how we're going to collect the data. We're going to use 4 sources for the items to include in our screening tool. So we're going to use the existing measures from the systematic review. We're going to do in-depth interviews with older adults with autism. And we're going to do 2 focus groups, one with researchers and clinicians from both geriatrics and pediatrics, and then have another focus group using the allied professionals. So include OT, speech, anybody that would work with older adults with autism. Then we will have an expert panel, which will include both professionals from geriatrics and aging, as well as family members and older adults themselves. The focus groups in the expert panel will be used to develop the domains for the tool, and the systematic review and the in-depth interviews will try and collect items to include in the measurement tool. So just a very quick overview here. The study team will then group all the items that we have into the domains. We'll pilot the screening tool. Then what we'll do is we'll use a Delphi consensus method, where we have an expert panel to review the tool itself. And so they will be asked to rate those items in terms of their relevance. It'll go through multiple rounds. Once there's an 80% agreement on the inclusion of the items, that will be sort of our final draft. The study team will then discuss determine the scaling and scoring of the tool. In terms of the psychometric properties, so sort of phase 2. So now that we've developed our screening tool, we'll then administer the tool into a group of older adults, age 50 and over, who have a diagnosis of ASD or a clinical suspicion of ASD. And then we will factor analyze those results. And the purpose of that is to see whether the items actually map well onto the domains that were created by the expert panel. And then items will be eliminated accordingly based on the statistical findings. We'll then do some reliability testing. So 1 month later, we'll re-administer the same tool to see if we can get similar results. We're going to do some hypothesis testing. And really the purpose of this would be to assess the validity of the measure. So we want to know, can the tool detect between those older adults that have autism and those that do not? Can it distinguish or differentiate between ADHD, for example, or anxiety, very prevalent comorbidities in this population? And can the tool and the subscales of the tool, does it correlate with existing measures for those known constructs? And then from there, based on the results of that, we would move on to assess the diagnostic validity. So what are the implications for older adults? Why bother to look at autism in later life? So it may be that detecting autism in later life allows better self-awareness for the person with autism and explain their existing behaviors. It creates a voice to a vulnerable group of older adults that has special needs. We don't really know anything about this group at all, so we don't know whether there's a change in the clinical presentation of this disorder over time. So once we have that information, it would allow people to be diagnosed appropriately and to seek and receive appropriate treatment and assessments. And having a diagnosis may allow them to access funding or programs that they wouldn't otherwise be eligible for. So a tax benefit, for example, if they are diagnosed with a disability. So how will the knowledge from this area of research impact care delivery? So the first thing I see is the importance of training and bringing awareness to health professionals that autism is actually a lifelong condition and that it is a possibility for older adults. The goal would be to eventually have the screening tool implemented into clinical settings. So that's on clinicians' radars of a possibility when examining symptoms. We don't know, for example, whether older adults with autism, how they would function in the community and whether they would require additional supports. Is the burden greater, for example, for family caregivers caring for older adults with autism? What does that look like? What supports are needed? In terms of long-term care, likely we would need new models of long-term care. So when you break down the features of autism, so for example, one of the things is the need for routine consistency. How would we do that in long-term care? If you just look at staffing alone, you've got 3 shifts in a day, high turnover rates in staff. How would an older adult with autism manage that? Lots of younger for sure. We don't know about what it looks like in older, but sensory issues. So if noise is a factor, or if people have issues with texture in the foods that they could or be willing to eat, how would that play out into long-term care, and how would we have to change the care delivered there? And really, I guess there's just so many questions. We really don't know anything about this area. It's an emerging area of research. I see the screening tool as the first step, but moving beyond that, once we identify this group, we really would want to look at the health and social characteristics. Are there higher prevalence of comorbidities in this group compared to the general older population? Standard treatment practices that we use, for example, pharmacological treatments, are they the same in older adults with autism? Or are they different? Are the guidelines different? What does dementia do? Added on top of an autism diagnosis, how does dementia manifest? Are behavioral challenges different? Are they more challenging? And then eventually, we really need to look at long-term outcomes. So I see incorporating the screening tool into the Canadian Longitudinal Study on Aging, which would allow it to be linked to other data currently being collected on the physical, the mental, the emotional, to be able to understand autism in older adults a bit better. So the goal really is to be able to have professionals identify autism as an issue in older adults while we're moving this research agenda forward. Thank you.
Questions for Julie? It's a big topic. It's overwhelming, I think.
What would be the sense of the prevalence of this issue in long-term care? How many people per 100,000 or whatever?
So right now there's very little prevalence data in older adults. What we do know, there's only been one study done. Sorry, I think I'm loud enough. Thanks. There's only been one study done in England, and it was a population-based study. It didn't include institutions, but the prevalence in older adults was similar to that in childhood. So we're looking at about 1% of the population.
Time for one more question.
I'm curious that if you're developing a screening tool for autism, and there really isn't a lot of information about autism in older adults, how do you go about doing that? I'm just having a little trouble putting my head around that.
Yeah, me too. So that's one of the challenges, and that's one of the reasons for that planning meeting that I talked about. So if we can unite aging researchers and autism researchers and kind of get them to talk. So one of the gaps is not having any diagnostic criteria. So that would be another step. So having a discussion around what would the diagnostic criteria look like. So it's really about bridging the gap, I think, between those two fields and drawing on developmental disability, because they've done a lot of work. For example, Down syndrome, right? There's been a lot of work around that. So I think we can draw on some of that knowledge. So the hope is to discuss some of the methodological and clinical issues in developing the tool through that research meeting.
So we'll continue on, but if you have other questions, please do come and see our researchers after their talk. Well, next move on to Deborah Schwartz. She's currently in her third year of her PhD in psychology at the University of Toronto and also at Rotman Research Institute at Baycrest. Her research focuses on exploring the relationships between adiposity and cognitive health and the impacts these relationships have on dementia risk. She has a BA in psychology from the University of Victoria and an MA in psychology from the University of Toronto. Deborah.
Thank you, Sue, and thank you to the OLTCA for having me. All right, so I'm going to talk today about the relationship between adiposity and cognitive health. So as many of you know, the current incidence of dementia in Canada is roughly 500,000, and this is expected to increase to about 1 million by 2038, which is a little bit under 3% of the population. So given this increase in prevalence, a pertinent question to ask is, why do some people lead long, cognitively healthy lives and others develop dementia? So there's a wealth of data that tells us that Alzheimer's pathology is actually present in the brain long before people decline to a state where they're diagnosed with dementia. And this is important to us for two reasons. One, it's suggestive of a long, slow-building trajectory. And two, it means that if we intervene early enough in these trajectories, we can hopefully alter the course of dementia development and reduce the prevalence of dementia. So one area of risk factors that's emerging in the research these days is cardiovascular risk factors. So it turns out what's good for the heart is also good for the brain. So in particular, obesity increases the risk of dementia. So what you see here is an increased risk of both Alzheimer's disease and vascular dementia given obesity from a variety of studies. Researchers are also beginning to look at the relationship between obesity and cognition, not just in older adults, but across the whole lifespan, so also in children and adolescents. So this is one such study from Verdejo and colleagues, and it shows that individuals with excess weight show increased interference on the trail-making task relative to those with normal weight. So what this translates to is that individuals who have excess weight are performing less well in executive functioning tasks. And this is sort of the class of cognition where we're seeing the most consistent relationships with obesity across the whole lifespan, but particularly in children and adolescents. However, it's not the case that all obesity is equally dangerous to our health. And part of this is due to how we measure obesity. So obesity is traditionally measured using the body mass index, or BMI, which is body weight divided by height squared. However, body weight is really heterogeneous measure. So we could weigh a certain amount because of fat, but also because of muscle and bone. So what this means is that you can have two people with really different body compositions, but that have the same BMI. So this is an example of this. This is an MR scan cutting through the body at the level of the thigh. So these two women both have a BMI of 29, and the woman on the left, as you can see, has quite a lot of fat in the green around the outside. The woman on the right has quite a bit of muscle. And both of these people are being classed in the same category, essentially in terms of their cardiometabolic health. They would be classed as overweight and actually quite close to the obese border. It's also not the case that all fat is equally dangerous. So subcutaneous fat, which is essentially the fat that you can see on a person's body, is not as dangerous cardiometabolically as visceral fat, which is the fat that grows inside of our abdominal cavity. So this on the right is an MR slice at the level of the abdomen, so right through the belly button. And this big white band that you see around the outside is subcutaneous fat. And the white that we see inside here, I'll just direct you a little bit more. This is the abdominal cavity wall. This is the spine, and these are the muscles around the spine. So all this bright white in here is visceral fat. And visceral fat is more dangerous for a couple of reasons. One is because of its metabolic properties. So it's more lipolytically active than other types of fat, which essentially just means it metabolizes faster. And also because of its location. It's drained by the venous portal system into the liver, so it kind of throws a lot more bad stuff into our bloodstream than other forms of fat. And this is important because it contributes to the negative effects of obesity, such as increased dyslipidemia, increased hypertension, and increased type 2 diabetes. All right, so we wanted to look at the relationship between visceral fat and cognitive performance in a population of adolescents. So I had 983 adolescents aged 12 to 18 from the Saguenay Youth Study. We had MR imaging of their fat, of their abdomen, and this is important actually because you can't quantify visceral fat with traditional anthropomorphic measures like body mass index or waist circumference. You can't really capture what's inside the cavity because obviously it's underneath your abs. We also had total body fat via bioimpedance, so you send an electrical current through someone's body, and then you can get from that measures of both fat and lean body mass. and then we gave them a cognitive battery. I'm going to focus just on the executive functioning results, because as I mentioned, that's the domain of cognition where we see the most consistent results. So we looked at a variety of components of this: processing speed, working memory, resistance to interference, and then also cognitive flexibility. So in our statistical models, we wanted to look at the effects of visceral fat, but also we wanted to see how that differed from other types of fats. We also included a measure of total body fat. And then because there are known sex differences in how fat's distributed in the body, we also looked at sex by visceral fat and sex by total body fat interactions. We controlled for a variety of covariates: age, exposure to prenatal maternal cigarette smoking, pubertal status, and household income. So what did we find? We found that on nearly every measure of executive functioning, we saw either a negative main effect of visceral fat or a sex by visceral fat interaction. And these effects were independent of total body fat, which wasn't significant, or when it was significant, it actually contributed positively, which is suggesting that it's visceral fat that's particularly dangerous in this relationship. Looking a little bit more closely at those interactions, we see that females with low visceral fat perform worse, significantly worse than females with high visceral fat, and we don't see a comparable relationship in males. So it might be the case that females are particularly sensitive to the negative impacts of visceral fat. And on a couple occasions, we saw a sex by total body fat interaction, and in these cases, we got a kind of double dissociation effect. So where females with low visceral fat perform the best, females with high total body fat perform the best, suggesting that total body fat might have a bit of a protective effect. Of course, it's important to remember that everything's controlled for one another, so it's not that all total body fat is good, but once you control for the amount of visceral fat someone has, having some excess total body fat might be helpful. So to conclude, it seems that visceral fat is negatively associated with executive functioning, and this is consistent with past studies showing negative associations between obesity and executive functioning. It also suggests that if visceral fat remains elevated across the lifespan, it could potentially have cumulative effects resulting in dementia later in life. It also seems to be the case that females are more sensitive to the negative impacts of visceral fat on cognition than males. These effects were independent of total body fat, and it also seems to be the case that total body fat could potentially be protective when controlled for visceral fat. And this is actually not as surprising as it sounds. Past studies have shown that elevated subcutaneous fat, when controlled for visceral fat, is associated with lower blood pressure, triglycerides, and reduced risk of metabolic syndrome. So thank you to the many people who helped me get my work done. Also, my affiliations, which I forgot to put on my slide, Baycrest and University of Toronto, and all of you for listening.
Questions? We're bouncing around topics and your head has to keep up with them all. What's that?
Hi. Can you hypothesize why females are showing a bigger effect? Because a similar sex difference is seen with physical exercise and cognition and the interaction with executive function.
Yes. I'm just going to go back to that slide. So I think at this point, what's happening is that the sex advantage is being eliminated. So you can see pretty clearly here that, well, here's a good one, that the females with low visceral fat are doing the best, and we know that they're, in our sample, and it's been shown in other samples, that we are expecting to see a female advantage in some of these capacities. And then with the high visceral fat, they're being brought down. However, I think this is going to change later in life. And you might see sort of a leveling out and an equivalent effect for everyone. And then I think after menopause, the whole game might change again. So we looked at spatial memory, and we didn't see any effect of visceral fat whatsoever. However, I don't necessarily think that the measure that we had was that sensitive. I think most people were performing their ceiling. Our sample shows a male advantage on verbal memory. I know that's really strange, but that's what happens in our sample. And we didn't really find any effects with visceral fat. There's sort of a borderline significant effect with one of the measures, but nothing really overall, and there was no interaction on that one. I don't know if that helps you delve into better hypotheses.
Thank you.
All righty.
So I'm going to introduce you now to Ashley Hope. She was one of our early researchers funded for some research last year who didn't have the opportunity to come last year. And so her research this year, she's continuing research, but not on this topic, but this is near and dear to her heart, and we're really happy to hear about what we funded last year. So Ashley Hope is currently in the first year of her doctorate at the University of Western Ontario. She holds an Honours Bachelor of Kinesiology and a Master's of Science with a specialization in gerontology from Lakehead University. Her Master's was exploring dog walking, motivation, health, and well-being. And her research interests include physical activity and aging, human and animal interactions, and psychosocial effects of disability and rehabilitation. In her doctoral work, she intends to explore how individuals living with Parkinson's disease and the social context navigate the disclosure of this diagnosis. So today we're going to hear from Ashley about her dog walking study.
Thank you so much, Sue. So yeah, I have a few different hats, and right now I'm going back to my master's work. And I'm not going to present my whole, the summation of my master's work, but just a little tidbit and try and make some connections to the long-term care environment so it's applicable to the conference. So I'm going to try and look at the role of dogs in supporting physical activity into older adulthood. So first of all, I just want to talk to some of the benefits of walking. And walking is sort of a physical activity that's near and dear to my heart, and was focused in both my undergraduate and my master's research. So walking is beneficial in that we can do it in many different environments. It's low cost and also requires little equipment. So we can do this, everyone can do it. It's great. In terms of benefits to our health, we have psychological benefits such as decreased anxiety and depression and improved mood and well-being. In terms of physiological and functional health, we see improvements in the risk of cardiovascular disease and other chronic disease, as well as it helps in the management of these chronic diseases, and also improves our mobility over the lifespan. And finally, in terms of social health, it helps us make connections and engage within our communities. So in spite of all these benefits, we have to ask, are older adults getting enough physical activity? So the WHO, or World Health Organization, recommends that older adults accumulate 150 minutes of moderate intensity physical activity during the week. And this can be done in as little as 10-minute bouts. So in the whole week, not very much physical activity. But regardless of this, 85% of individuals 40 to 59 and 87% of individuals 60 to 79 don't meet this guideline. So, that's most of the population. Kind of scary. What I was looking at, though, is a subgroup that has an increased propensity to meet these recommendations. So in the literature, dog walkers are seen to be more likely to meet these recommended levels of physical activity. Dog walking as an activity also has sort of been seen to protect against seasonal decreases we see in the winter in physical activity. And dog walkers overall have higher levels of physical activity in general, lower BMIs, and are less likely to report or have lower odds of reporting diabetes, hypertension, hypercholesterolemia, and depression. So, kind of neat individuals in terms of the physical activity seen. So what I'd like to do is just to present some of the results I had from my master's, demographic and dog walking results, to sort of bring some more insight into this form of physical activity and then make some connections to long-term care. So in my whole study, I engaged in a mixed method study, and so quantitative data was collected from 94 individuals, and this included the demographic and dog walking data I'm going to present, but also some motivation data and health and well-being data. And then I followed up with 9 interviews with individuals that were deemed regular dog walkers, or individuals that walked at a minimum of 150 minutes per week with their dogs. In terms of demographic data, just to give you some idea of what I was dealing with, the majority of my sample were female. And as you can see from the graph, the majority of individuals fell between 55 and 69. And I'll speak to that in just a moment. Additionally, the large proportion of my sample were very educated at either the college or trade school level or higher, possessing graduate or professional degrees. 70% of the sample were married, and 90% lived in a detached home, and 80% resided in the city. And I just wanted to speak to the age effect and also the living accommodations that individuals in my study had. And one of the things I found when I was collecting data were that previous dog owners that no longer had dogs were coming to me saying, "Oh, I'd love to participate, but I don't have a dog anymore." Okay, why not? So there was concerns as people aged that they wouldn't be able to care for a dog if they were to pass away, or if they had to go into a long-term care facility and wouldn't have someone to look after their dog. As well as the fact that in certain housing, such as apartments, long-term care, assisted living facilities, it's not always possible to have an animal in those situations. And sort of one of the most profound things I think came out of one of them that was most profound for me, was that 88% of my sample engaged in some level of dog walking during the week. And what that means is, regardless of the guidelines that are recommended, 88% of individuals at some point went outside and walked for whatever amount of time with their dog. And the average in the summer or more temperate months was about 247 minutes per week of dog walking. And in the winter, we see about an average of 186 minutes. So we did, although the days were fairly consistent over the seasons, there was a significant decrease in the amount of time. Taking into consideration, I collected data in Thunder Bay. Thunder Bay gets very cold in the winter, so the time, it gets very cold in the winter. It's freezing. And it gets very dark early. So people still went out the same amount of times, but just for shorter bouts, but still well above the recommended levels of physical activity that we'd hoped for. And just to speak to some of the comments and insights from my participants, in general, they viewed dog walking as a valued activity. It was something that got them outside on those cold days when they weren't feeling like it, and just something enjoyable that they did with their companion. But from collecting data, I wondered what happens for those people that don't have dogs or can't have dogs, and what happens in long-term care for people that have been previously dog owners and might benefit from this type of physical activity. So I just looked at some studies that have used sort of a borrowed or a loaner dog type of model. And there aren't very many, but the few that I have found use shelter dogs that have been trained and are facilitated with a handler that go and perform a walking program with individuals. The first one was in public housing, and those individuals found that they're motivated by the dogs and their relationship with the dogs so that they wanted to continue doing the walking program. And then one study I found was also just more recently in long-term care, and that in this they had two different, like a control walking program and the dog walking program. And overall, all of the participants saw an increase in walking time, which is important, so about an average of 7 minutes. But those people that were paired with dogs felt motivated by the dogs, and the important role of motivation in adherence to physical activity. So when we're motivated, we're more likely to adhere to physical activity, and that means we're going to continue and benefit from the activity we engage in. So just to summarize, the results, nice and brief, the results of my study sort of indicated to me that dogs help facilitate physical activity, and this can be throughout the year and throughout the lifespan. And when we interpret results from community-based studies or these loner dog studies in conjunction with the loner dog studies, we can see the potential for dogs to facilitate physical activity through the lifespan, regardless of where you live. And that it can be a useful inclusion within long-term care to provide motivation for individuals that may no longer want to perform physical activity, and that it provides sort of a meaningful, different way of engaging in physical activity that will motivate and help adherence. Thank you.
Questions for Ashley?
Actually, I walk my dog every morning, and I can't convince my wife to walk with me, so it's amazing you had all females. So my sample is all male. Anyway, the one thought, I do lots of falls research, and of course we know in homes animals actually are a particular risk factor for falls. But on the positive side, I was imagining that in the a long-term care home, that maybe we could have dogs that are not only trained to walk with people, but also trained somehow that they could actually prevent these people from falling by offering some kind of a structural setting. It would be pretty cool if long-term care people actually were prevented from falling and walking at the same time somehow. I don't know how you do that, but it does speak to the fact that you'd likely have to have some special kind of trained dog, just like we do for children with autism and so on that are, have... Anyway, that was just my thought. I love dogs.
Thank you. Just in these sort of shelter loner dog situations, they're usually shelter dogs that have been trained and gone through this program that work with a handler. So they walk with the dog and the handler. And the benefit's twofold. So yes, people get physical activity, but the dogs are also walked and socialized so that they're more adoptable, which is really important for in terms of shelter dogs and making sure that they get good homes.
Sounds too late to switch out a Parkinson's dog.
Dogs are my side research, but yeah.
So maybe as well as the wee fit, they need a wee dog?
Yeah.
Or a big dog.
Yeah, he's a big guy.
Dancing with Parkinson's, walking with Parkinson's.
Yeah.
Perhaps there's a motivational and momentum factor that could be imparted by dogs for people with Parkinson's.
Definitely. I have, a lot of ideas brewing, and it's just, red tape and ethics and all these things that you have to consider. But, yeah, I think it would be really neat. There was one study that was done in Japan, and it has to do with autonomic functioning in what happens when you interact with a dog. I'm not going to pretend to understand that side of things, but it helps elevate some of the levels that we see decreases in Parkinson's disease. So I'm not sure yet, but I see some application there, definitely, in some side research from my main research program.
One more question for Ashley at this time. Okay, last but certainly not least, we have Kayla Regan. She's currently in her first year of her master's degree in neuroscience in the kinesiology department at the University of Waterloo. She has a BSc in kinesiology from Waterloo as well, and is currently working under the supervision of Dr. Laura Middleton. Her research interests concern the development of strategies to prevent and or delay the onset of dementia, and her immediate research goal is to explore the use of exercise as a strategy to prevent dementia, and how exercise dose can alter cognitive function among older adults. She plans to continue her education and research with a PhD regarding exercise interventions among cognitively impaired older adults to improve cognitive function. And today she's going to talk about physical and social opportunities in retirement communities.
It's only 9 pages.
Josh, it seems to be not loading.
Oh.
Yeah,
Okay.
It's not, the little green light's not moving. There we go.
But that's not my
Well, maybe that's one. It didn't want to do that one again.
There we go. All right, so thank you, Sue. And so the work that I'm going to be presenting right now is a bit of pilot data that we're currently working on right now and started about a couple months ago, and will be continuing for the next probably year, possibly longer. So basically the title of my study is Physical and Social Opportunities in Retirement Communities, Who Benefits and Why. So a little outline for my presentation today. First I'm going to cover some background and rationale for why we're doing this study, followed by the objectives, methods, and results of the collected pilot data thus far. And then I'm going to touch on some future directions for what we plan on doing throughout this upcoming year. So we know that physical and social engagement is important to the health and quality of life among older adults, as it has been observed that people with higher levels of social engagement and support have lower rates of dementia,
and higher likelihood of a healthy aging. Unfortunately, some older adults are unable to participate in physical and social activities on a regular basis due to several limiting factors. These can include things like social isolation, driving restrictions, mobility issues, and these are just to name a few. It is hypothesized that retirement communities may provide greater access and therefore improved involvement in physical, social, and cognitive activities. So there's three main objectives to my study. The first one will be to determine whether engagement in physical and social activity changes as older adults transition from living at home in their neighborhood community and into a retirement living facility. The second is to determine whether these changes vary by participant subgroups, and by subgroups I mean by differences in age, sex, cognitive function, personality, these types of characteristics that we're going to control for. And third is to determine whether these changes are associated with corresponding changes in cognitive and/or physical function. So the methods for the pilot data, we have recruited 9 participants so far from the Schlegel villages, and these are residents that have moved in within the last 2 years. They performed self-reported questionnaires to assess their current and past, and by past meaning within the year prior to moving into the retirement village. They assessed their physical activity using a CHAMPS questionnaire, as well as their social activity using a leisure inventory and social network scale. So just some results that we've seen so far. As you can see up at the top graph, it actually shows that their past activity, they seem to report higher past activity versus current living in the village, which is actually the opposite to what we hypothesized, which was a little disappointing at first. But it did provoke us to further investigate the reports of their activity counts. And we broke their physical activity into 2 separate groups. The first group being purposeful activities and the second group being everyday living activities. So by purposeful activities, these included things like aerobic classes, use of fitness equipment, walking for the purpose of exercise. So basically more moderate to higher energy expenditure activities. Whereas the everyday living activities included things such as vacuuming, dusting, gardening, other stuff that you would normally do around the house. With this being broken up, we did notice that there was quite a dramatic increase among the majority of the residents in their aerobic fitness class activity as well as their purposeful activities, which was a great sign. We saw a dramatic decrease, though, in their everyday physical activities, and this was because in the retirement homes, all these things are already done for them. They don't have to clean their apartment. They don't have to do these things. The people working at the retirement facility do this for them. So that's why we think that the research so far has shown an overall decrease, when in actuality, their purposeful physical activity is actually increasing. So moving forward in the upcoming year, so far we have only looked at current residents, and we're hoping to physically capture the transition from community living into retirement living of those that are currently on the wait list to move into a retirement facility right now. So up here is just the protocol laid out of the activities that we're going to perform for the people moving into a retirement facility. So it will consist of 3 separate visits. The very first visit will be within 3 months before they are notified that they will be moving in. At this time, we're going to do the same physical and social activity reports that have previously been done, as well as they're going to be wearing an activity monitor for 72 hours to try to quantify what they're reporting on the physical activity questionnaire. Their second visit is going to be immediately when they move in to the retirement facility. At this time, we're going to do a battery of cognitive tests, as well as a senior fitness test to assess both their physical and cognitive function at the time of their arrival to the retirement village. And the third visit is going to happen approximately 3 months after they have already been living at the facility, so that it gives them a chance to move in, get settled, get used to things, and see what activities they begin to take part in, stop taking part in, or continue to take part in. At this time, we are going to then repeat all the measures that were done at visits 1 and 2, that being the physical and social activity reports, the cognitive assessment, senior fitness assessment, as well as wearing the activity monitors again at this time. We're hoping to see that if any physical and social activity changes over the 3 months of them living in the retirement home, if those changes also correspond with any changes in cognitive function and or their fitness level function, because that's ultimately what we would like to see. So why do we think that this is important, and why is it relevant to today? Well, this study looks at the investigation of the impact of an alternative health care method, that being a retirement living facility, on behavioral factors such as physical and social activity habits that may reduce the likelihood of needing long-term care. It is hypothesized that by identifying potential benefits to this alternative care model in a retirement facility, we may be able to develop strategies to reduce the need for long-term assisted care among older adults and promote independent, healthy aging. And that's all. Thanks very much. Questions for Kayla?
Thanks for the talk. I was just wondering, putting Ashley's talk together with yours, whether Schlegel Villages allows dogs and if there's barriers to having dogs at Schlegel.
I actually don't think I can comment on that. I have no idea whether they will allow that or not. But after hearing Ashley's presentation, that actually sounds like a really great idea. So I don't know. I'm sure there's plenty of people here today from Schlegel Villages as well as RIA. So possibly hit them up with a suggestion of that and see where it goes.
Actually, has the CHAMPS been validated for older people? I mean, clearly it's been validated for school populations and that kind of thing.
It is a modified version, so it has been validated to the same extent I am unaware of. It's basically, we're just using it as pilot data for right now. We are in the midst of looking for possibly other questionnaires to use in conjunction with it as well, because its validation has been questionable over the age of 65. So we are working on that.
Yeah, I just had a student collect CHAMPS and accelerometer data on high school kids, which CHAMPS is supposed to be valid for, and they were so dramatically wrong, and their parents, that it was like they weren't even in the same universe.
Yeah, which is why I recently suggested to put in the activity monitoring. We were using a sensor activity monitor, which was an armband that essentially captured energy expenditure just based on predicted values. We're now looking at an actigraph activity monitor, which is worn on their hip, that's capturing three-dimensional movement. So we're hoping that that'll help to quantify the future data.
I would put a heart rate monitor on them too, actually.
In conjunction,
yeah. I would use both, but just my own.
Mm-hmm. No, that's a good suggestion. Thank you.
The findings with respect to the purposeful exercise versus the everyday living exercise are interesting. Did you look at how those two types of physical exercise correlate with cognitive ability?
We haven't, no. I do know that moderate activity has been shown to show the best cognitive results. Light coming up second before higher intensity. I think the only problem is that when people do report, I mean, these are just based on self-reports, and I don't know this for sure, but from my experience, I feel that people very much overestimate the amount of day-to-day, everyday activities that they are doing, that is actually probably a lot lighter and a lot less time-consuming than they're quantifying them to be. So I think it's a little underrepresented.
Okay. But with respect to their cognitive ability, it's more the moderate.
I believe, right, which is why we ended up breaking it up. So when we first saw, we're like, well, this is showing the negative effect of what we wanted to see, but in actuality, we don't believe it is, since the purposeful activities, which is the moderate intensity activities, are in fact increasing. It's just our overall count is decreasing due to the fact of the everyday activities decreasing. But with those only being light energy expenditure activities, I don't think that those are contributing to the cognitive impact that we would or would not see.
Thank you. Very interesting study. I was just wondering, just a curiosity question about your methodology and why you chose not to do cognitive assessments while people were still living at home or before they moved into the Schlegel Village.
Oh, for the future protocol, we are looking to do the cognitive assessments, like essentially the week when they move in, because we'd like to minimize the amount of time, the time frame between, since we know that deterioration happens very quickly at an advanced age. The reason why we aren't doing the cognitive assessment right now with the current residents is they already live there, so we have nothing to compare them to. Like, I didn't know these people 2 years prior before they were moving into the village. So to take a cognitive assessment right now wouldn't be beneficial because I don't have the ability to compare it to before they moved in. Does it? Oh, it's because it was on the second visit, which was initially when they move into the home, so within the very first week. So ideally that would still capture their cognitive function from when they were in the community. We just don't want to have it separated by greater than 6 months' time because that's a great amount of time at that age.
So I'll open the floor to questions to any of our early researchers at this point. So we had Stacy talking about music students, and then we had Julie talking about the autism tool. We had Deborah talking about the intra-abdominal fat and its association with cognitive performance. Ashley and her dog walking study, and then Kayla and the physical activity opportunities in the village. So any questions to any of them about any pieces are welcome at this point. It's been a long day. One of the things one of the mandates of the ORC is to have a phone ring here. That's really bizarre. One of the goals is to build capacity in research students, but also to get a lot of people to be able to network together across all of our research institutions. So these researchers and another 10 more or so are going to have a networking event tonight, and then we're going to have more presentations just to our internal group tomorrow. So we will continue to make those connections so that dog walking and opportunities for activity within villages and all of these things start all blending together, and that the early researchers and indeed our senior researchers get to meet and greet and make those connections over the next 2 days. So great job, everybody. And any other questions for anybody at this point? And please do come and visit them. We've got a few more minutes, but if those of you want to get a few more 5 minutes of physical activity before the next talk, we encourage that as well. So thank you, all of you. Cool.